Thanks, Mira. So hopefully I'm not going to present unclassified tumor, first of all, because that'll be too difficult. So case 3 is a 19-year-old Caucasian man, young man, and then he presented to his primary physician due to right upper quadrant fullness. He had weight loss in the previous few months and also intermittent back pain, but doesn't really require painkiller. And by imaging, it was found that he had a very large 12-centimeter right renal mass. And also imaging revealed multiple lesions in the bone and lungs. And he also had enlarged subclavicular and mediastinal lymph nodes. Because his age, his really positive past medical history has been allergy. And his father, mother, and siblings, he has 2 brothers. They are all healthy. But indeed, his paternal grandfather died of kidney cancer. So that's sort of giving his age ring a lot of bells. Giving the sort of a clear clinical picture of a metastatic renal cell carcinoma, he underwent a cytoreductive radical nephrectomy. So as you can see by this gross picture of the case, there's a very large multinodular mass replacing a large portion of the kidney and extending into the renal hilar fat. The tumor, as I mentioned, measured 12.5 centimeter, and the cut surfaces are very heterogeneous and it's partially cystic. By microscopic examination, we found there's perinephric and renal sinus fat invasion. Also, muscular branches of renal vein was involved, and there's extensive lymphovascular channels involved by tumor. The tumor also extends to the adrenal gland by direct extension, therefore a T4 disease. And in addition, there are 19 of the 25 regional lymph nodes was involved by tumor. So this is a really awful tumor for this young man. So under microscopic examination, these slides show one of those nodules at the pushing border of the tumor. As you can see, they're composed of high-grade cells forming tubules, and it has an infiltrating growth pattern. As you can see, there's some benign renal tubules was retained within the tumor. There's also a suggestion of a desmoplastic stroma, which become more apparent in other areas. And the tumor cells, besides forming tubules and also forming these nests or individual cells or trabecular growths, and in areas, you can see the tumor cells become spindly, and this is consistent with sarcomatoid differentiation in this tumor. So a large portion of the tumor consists of this solid nested growths. As you can see at this higher power view, many of the cells have very prominent nucleoli and cherry red, and even higher power, even you can pick up some occasional nuclei with paranuclear halos. So that's a very clear indication for people ever trained at MSK in recent years. So there are some other area of the tumor. You can actually finally appreciate there's actually low-grade component at the present. And you can see in this picture, there are high-grade nests area composed of cells with apparent very high-grade nuclear features that, immediately adjacent to area that with low nuclear grade. And at higher power, can see these cells having a pale eosinophilic cytoplasm, and that there's a lot of cytoplastic vacuoles, and also you can find occasional eosinophilic globules. And those cystic space noted on the growth examination largely correlate with those large cysts, mostly in the solid areas, and the cysts are lined by the same type of tumor cells in the adjacent regions. As you can already pick up from here, you can see at higher power, this different type of cells I just described actually transition into each other. You see the low-grade area, high-grade area with eosinophilic cytoplasm, but also more basophilic cells forming tubules that the cells but all the tumor cells appear to be, from the same tumor. So given the patient's young age, we scratch our head and we come up with this differential diagnosis that probably is different from you would expect from an older patient. So this is taking into consideration the incidence of renal cell carcinoma in this age group, and as well as a potential underlying syndromic condition in this age group. So this including, the MIT family translocation associated RCC, including the XP11 and the 6E11 translocation RCCs, and the renal medullary carcinoma, hereditary leiomyomatosis, and renal cell carcinoma syndrome associated RCC, succinate dehydrogenase deficient RCC, the ALK-translocation associated RCC, and tubular sclerosis complex associated RCC. And at the end, of course, if you cannot classify it, I think we would probably end up with calling it unclassified. So our hope is we will end up somewhere above that. So because all these are very rare tumors, I would like to just briefly touch base on some basic knowledge now we know about these entities. So as I mentioned, the MITF translocation tumor probably is the most commonly in children and young adults, but it can also occur in older population. XP11 translocation accounts for probably about 20 to 40% of all pediatric RCC. And variable fusion partners has been identified, and some of the more established ones are listed here. The most common two are the X17 translocation involving the ASPSCR1 gene, and also the X chromosome 1 fusion that involving the PRCC genes. Dr. Antonescu sitting here has contributed a lot to the knowledge in this aspect. And for 6E11, the known partner is between the alpha and the TFEB gene. So for quite some time, we have been thinking about translocation tumors when we see either tumors with, on the right-hand side, if you have a very abundant voluminous cytoplasma with papillary or pseudopapillary architecture, with the psammoma bodies, with this, a lot of clear cell cytoplasma, or on the left side for the X11 translocation tumor have the more alveolar pattern, growth pattern with slightly smaller tumor cells. But now I think with the increased using of TFE3 and TFEB immunohistochemistry and FISH, we are discovering many more tumors that has variable morphology. This nice review written by Dr. Agani at Hopkins emphasized some of the more rare variants of the XP11 translocation tumors. As shown here, you can see some of the tumors can closely mimic a low-grade oncocytic renal cell neoplasm, and some others are more showing a tubular anastomosis tubular or papillary architecture, while others have clear cytoplasma and the linear arrangement of the nuclei mimicking clear cell papillary renal cell cancer. A same picture also appeared for the 6E11 translocation tumor, and also for both type of translocation tumors. We are recognizing also overlapping of their morphological features. Because for the sake of time, I'm not going to cover the 6E11 tumors, but for renal medullary carcinoma, we all know this is an entity we have known for quite some time. It's an aggressive tumor associated with sickle cell trait, or rarely with sickle cell disease. In most patients, mostly of African American or Mediterranean ancestry, and the tumor has a relatively characteristic histological features. We often see this sort of quibiforming architecture patterns. Many tumors have a very prominent mixed inflammatory infiltrates that with a dominant neutrophil population. And most of the tumors reported so far commonly show NY1 loss or SMARCB1 loss. as shown here. So because, I think the availability of this immunohistochemistry method in our lab, is helpful for us to make the diagnosis. And then touch base on the hereditary leiomyomatosis and renal cell carcinoma, the HLRCC. So this is related with the germline mutation of the FH gene located on 1q for 2 or for 3. And the patient often have cutaneous and uterine leiomyomas, and they 20 to 30% of the patient also can present with aggressive renal tumors, and not very obvious for people to look at them because they are often unilateral, unlike some other hereditary conditions where you often have bilateral multiple tumors. And the patient usually have poor outcome because the tumor metastasized early. So in 2007, Dr. Marino described the one characteristic histological features of these tumors, which is the cherry red nuclei with the perinuclear halo. They're very prominent in these tumors. And in that cohort, she described the papillary tubular papillary solid, and mixed architecture patterns, and also cystic component in these tumors. We conducted a retrospective study of this group of tumors published in 2014. These 9 cases were all actually initially presented as sporadic RCC, but later was found to have germline FH mutations. So we described some additional architecture patterns, including collecting duct-like or tubular cystic carcinoma-like growth architecture patterns, sarcomatoid differentiation, and also the tumor cells can have very prominent cytoplasmic vacuoles, almost like sieve-like appearance. And this is expanded histologic spectrum, and then we also really needed some ancillary tools to help us with the diagnosis. So because of the high level of fumarate accumulate in the cells that lacking fumarate hydratase, so based on a previous study, and they describe an antibody that can recognize this very specific chemical modification happening when you have high level of fumarate, which is called 2SC, and using this antibody we found is very helpful for distinguish HLRCC-related renal tumors from other high-grade RCC. And in this study, we found that the 2SC show a very sort of relatively specific and a nuclear and cytoplasmic staining pattern in these tumors, in contrast to other tumors are mostly negative or have only cytoplasmic staining. And or you can try to use immunostain directly stain the fumarate hydratase in these tumors, and which also shown very good specificity, but the sensitivity in our experience was a little bit lower. In this study of 14 cases that with confirmed FH germline mutations, we found 2 of them could have retained FH staining or have heterogeneous staining pattern. So with the help of these ancillary tools and also, the power of next-gen sequencing, in one of the recently just completed and published multi-institutional study of tubular cystic carcinoma with poorly differentiated foci that we participated, actually 19 of the 29 cases, 65% cases, actually was found to be, having either positive 2SC staining that also FH negative, or have the positive 2SC staining which retained FH staining but was found to harbor FH gene alterations, suggesting this histologic subtype we described before in the, other people described before in the literature actually may represent just a morphological spectrum of the FH-deficient RCC. So as you can see here, the FH staining showing loss of staining in the tumor cells in contrast to the retained benign renal tubules, and the 2SC showing very strong staining in all tumor cells in contrast to the glomerulus here. So, and the next hereditary condition is the SDH-deficient renal cell cancer. This has been published by a few groups and describing the very unique histological findings. As we know now, so this tumor are associated with the pheochromocytoma, paraganglioma syndrome type 4, PGL4. So they often have, or most commonly have, the solid or focally cystic growth with uniform cytology. The most common features was found was the eosinophilic flocculent cytoplasm, the intracytoplasmic vacuolations and inclusions. So some of this would, remind you of some of the low-grade area we saw, but, that tumor was really dominant by a lot of high-grade disease. So for this entity, immunostain for SDH-B turned out to be very helpful, not just detecting SDH-B mutated tumor, it also can help detect tumors that with either SDH-A or SDH-C or SDH-AF2 mutated tumors, because I think they are forming a complex. So once you lose one of them, the complex collapses. So the SDH-B staining actually reflects mutation of them, at least in the reported cases so far. So as I just mentioned, so most of this affects young adults and has in most cases have an indolent course, unlimited follow-up. However, some patients has been reported to have widespread metastases and poor outcome, but the knowledge in this aspect is pretty limited. So lastly, is it lastly? No, not lastly. And also the tumor sclerosis-related RCC is a well-known, hereditary condition. So I'm not going to say too much about it, although WHO hasn't formally recognized as a distinct entity because the histology is so heterogeneous. Two recent papers published last year describing basically 3 groups of tumors that are red-like, meaning the renal angiomyoma tumor-like morphology, meaning it has smooth muscle bundles in the stroma. In those tumors, you often see clear cytoplasm and papillary architecture. And the hybrid oncocytic chromophobe-like group that in some area could bring into mind our tumors as well, which have this nested growth with sort of slightly pleomorphic nuclei and some nucleoli, primary nucleoli. And also a granular eosinophilic macrocystic morphology that has been that's morphologically very similar to a recent described somatic entity called a eosinophilic solid and cystic renal cell cancer. Of course, I think there are still other tumors with sort of unclassified or described morphology in this group of tumors. And also there are cases reported regarding the ALK-translocation associated RCC. This is really an emerging entity in the current WHO classification. There are only about 10 cases reported in the literature. It can occur in both children and adults. The fusions identified in these tumors, the fusion partners identified in this, mainly including vinculin with VLK, TPM3, EML4, and the recently reported STERN as TRN. But interestingly, most of the cases reported in the pediatric population all harbor the vinculin and ALK fusion, and those patients all had sickle cell trait. So, and this is the first reported case harboring this VLK, the vinculin and ALK fusion. As you can see, again, it's a pink cell tumor with high-grade nuclei, which puzzles us so much every day. And it also can have cytoplasmic vacuoles. And as shown here in this picture, the morphological spectrum of some other fusions involving ALK is still sort of, I think, understudied because the case number are still very low. So we see, some morphology, in our tumor was sort of showing resemblance of this. So what it is, and so we conduct some of the immunohistochemical studies. So first of all, it's PAX8 positive. This is consistent with renal primary, and it's TFE3 and negative. So we didn't pursue to fish at this point because before we complete some other immunohistochemical studies, and showed the NI1 retained, and the 2SC is negative despite the perinuclear halo we saw. And the FH is retained also, supporting that diagnosis that is not HLRCC-related tumor. And some of the common renal cell markers that we commonly do is CA9 negative, CD117 shows focal variable staining, CK7 is focal and variable, and the ALK is negative, and SDH-A is retained. SDH-B, when we finally use two different antibodies, we were able to find actually one of them showed consistent loss. And this is the picture from that second antibody, and showing all tumor cells lost the SDH-B staining in contrast to the internal controls that was vessels or inflammatory cells. So our final diagnosis, this is SDH-B, this is SDH-deficient renal cell carcinoma. And given his young age, the patient undergone genetic counseling and had the genetic testing done. So the germline DNA sequencing was performed for all coding exon of the SDH-B, CD, and AF2 genes. And only the SDH-B gene showed a deletion of exon 4 and 5. But interestingly, the patient's mother and the brother also have the same SDH-B alteration, actually suggesting or confirming it's a maternal inheritance. So the paternal side, that history of renal cell cancer is not relevant. And later we found out it's a clear sum morphology, so proving it's actually false. There's not a real family history for this disease. So the clinical follow-up is a little bit depressing, and the patient was first treated on a clinical trial with concurrent anti-VEGF inhibitor and mTOR inhibitor, and followed by off-label use of more tyrosine kinases, as well as the standard therapy for renal cell cancer, the sunitinib, and without any objective response. So the patient died 9 months later after the initial diagnosis. So we found this case was sort of like a really, because before we saw this case, we were thinking that SDH-B is relatively an indolent disease, but this case was so aggressive. And so we reviewed our, with the availability of the SDH-B antibody, now we reviewed and did more study. So here I'm just describing our recent SDH-B deficient RCC cases that we see at MSK. So they're including 9 cases. This case is one of them. And among these 9, you can see 4 of them had pretty widespread metastases and all died of disease. And the patient age, the oldest so far is 54, and the youngest is 18-year-old. So the architecture patterns, we summarize here in this table. So this tumor, having, it's number 5 here, having, they showed you the collecting duct-like region, sarcomatoid, solid nodular, alveolar tubular nested patterns, and some of the HLRCC-like cytological features. Similar features been seen in other tumors, but not all the tumors showing all the architecture patterns. There's a really wide spectrum. And but we do find usually high-grade cytological features that correlate with the metastases and more aggressive behavior of the tumor. And some of the examples of the patterns I haven't showed you in this case, as you can see, some tumors have this more tubular arrangement that mimic or pseudo-papillary arrangement that really mimic some of the translocation-associated RCC or papillary RCC. And some of the tumor can have a prominent tubular cystic architecture pattern. Of course, you don't have the hypocellular stroma. Here you have more cellularity within the stroma, but this would also bring up the differential for the HLRCC pattern I described earlier, and maybe some other tumors. So at the high power, you can see the cysts are lined by cells with high-grade nuclei and a lot of cytoplasmic vacuoles. And other tumors, also similar to HLRCC, showed a lot of sieve-like vacuoles. And some of the low-grade tumors can have areas mimic mucinous tubular spindle cell tumor with tubules and mucins. So I think our knowledge about this entity is still in the early phase. We still need to learn a lot about it. But importantly, I think from the case that we realized that SDH-deficient RCC encompasses a broad morphological spectrum beyond the typical low-grade histology. it should be included in the differential diagnosis of a high-grade RCC, particularly in younger patients. And SDH-deficient RCC appear to behave aggressively when harboring high-grade morphological features. Thank you for your attention.